morning, everyone. Good evening. If you are in Singapore, like our guest today, Professor Theo Kofidis. Good evening, Theo. Welcome.
Good morning to Chicago.
Yes, or good morning if you are in Chicago. This is another one of our live stream appointment that I organized literally from the living room of my house, a way to connect with excellent cardiac surgeons around the world, to talk with them, to learn from them in a very friendly way on a Saturday morning for me, Saturday evening in Asia, or a Saturday afternoon in Europe. Inspired by the wish to try to learn and have something new to adapt in our current practice. Today, I'm extremely happy to have here with me Associate Professor Theo Kofidis, an absolutely unique man and unique cardiothoracic surgeon. He's Associate Professor and Head of the Cardiothoracic and Vascular Surgery at the National University of Singapore. He has been trained in some of the world's leading institutions in our field. He completed his medical education in Germany. He then pursued more training in Texas Heart, in Rochester in United States, back in Hanover, and then again in Stanford. And he's currently in Singapore. So a completely world-based, wide training and broad spectrum cardiothoracic surgery. He's extremely prolific academic surgeon, very strong and exceptionally strong know-how in minimal invasive. He dedicated himself in expanding minimal invasive cardiac surgery in Southeast Asia, proctoring around the world, and create a state-of-the-art simulation center of minimal invasive cardiac surgery at the National University of Singapore. So welcome. Good morning or good evening, Theo. Thank you so much for coming here today.
Thank you for your hospitality, Gianluca.
The main reason why I really wanted to organize this friendly conversation among us was your new book that if I'm not wrong, just came out a couple of weeks ago. Is that right?
Correct. The book was launched by the publisher, Taylor and Francis, CRC Press, on March 26, literally a week ago.
Fantastic. And the name of the book is Minimal Invasive Cardiac Surgery, A Practical Guide. And, we host other books editor before the launch of their books. And I had the opportunity to review the books just before this meeting. And I must say, Theo, you did an absolutely incredible, mind-blowing job with your book. This is more than a book. Tell us a little bit more about it. What is the uniqueness of this book, and what is what the reader or potentially the purchaser is going to expect when he buy the book?
First of all, thank you for the encouraging words, and I take them as I will convey them to the entire editorial team and everybody who contributed. Well, our book has two main differentiators. The most important one is that we would like to think that we are launching a new educational concept, not just a book, because it involves QR codes. That means that anytime when you read a chapter in the book in minimal invasive cardiac surgery, every page almost has a QR code which you can scan with your phone, and it takes you it links you basically to the internet where you find a plethora of videos and you can see how the surgery is done. The second differentiator of our book is that the chapter structure is really a practical guide. We didn't want to invest too much energy in writing about the pathology, histology, or the history or differential diagnosis of the disease, as it is oriented to surgeons who are pursuing a practical task to learn minimal invasive heart surgery. So it's all about how to do it, how not to do it, what to avoid, caveats and tricks, alternative techniques by others, where to learn, how to learn, and so on. So these are the two main differentiators.
Yeah, and I found it extremely unique. I mean, this idea of the QR codes, let's stay here for a minute, because this is, for me, was a revelation. Exactly last night, you shared with me, I was in front of you, the PDF of the book. It was midnight. I was scrolling down the pages on my computer, and I had my phone, And while I was reading with my phone, I can go in front of the video of my computer, in front of the QR code, and I can go and hear a presentation about minimal invasive cardiac surgery that is currently present on CTSNet. And it was actually a very inspiring presentation. And I had the opportunity to listen to it for the next 20 minutes. So an integration of technologies, not only a book, but literally a new, as you said, educational platform for where did you come up with this idea? Where did you see it? It is an original idea. What is the...
Well, the idea came to me about 5 years ago already. And around that time, I bumped into I believe at that time, CEO of the publisher, Taylor and Francis, which is one of the biggest medical publishers or general publishers around the world. So, but the idea arose from a pain point because as heart surgeons, our surgeons, or even doctors in general, in 2021, in our times, where we have so much plethora of internet opportunities to learn, we would like to watch, we would like to see how it is done, how the procedure is done. I felt that heart surgeons, on a lighthearted note, don't read anymore. I mean, we do update ourselves through the mainstream journals, but we don't really read books as we used to do 20 or 30 years ago as the basis of our postgraduate education. What surgeons would like to do nowadays, and that, of course, tallies with my experience from proctoring all these years, is to go and see how it's done, or visit YouTube. Professor YouTube is the best teacher nowadays. So
you're right. Absolutely true. Absolutely true.
And visit conferences and see with their own eyes how it's done. So basically, the heart surgeon nowadays has the opportunity to employ totally new internet multimedia learning experiences. So I thought, why don't we provide surgeons, doctors, nurses, perfusionists with an experience rather than just reading through the plain text of a book? So this is how it started. And then, of course, the CEO at that time, or the gentleman who spoke to me, I think it was the AATS conference in the United States, of course, asked me to do my due diligence. I had to write an application to the publisher and to expose my idea to the usual scrutiny. I was impressed how peer-reviewed this process is. It's not like you knock on the door, you ask for your idea to be published. So it's very, very, very structured. So it had to go through the internal committee of the publisher. It had to go through independent reviewers who are all authorities in the field around the world. Amazing. And we ended up having a unanimous decision. They liked the idea very, very much for a full-scale production with color images, graphs, tables, and of course the most difficult part, which is the QR code. Yeah. So that's how it materialized.
It's fantastic. And I have to say, this is an example. I prepared this small PowerPoint with 3 pages. First of all, extremely high quality pictures. And I think that in the current state, it's absolutely important. Second, for what by reading it, what I found extremely valuable is the fact that it's a direct approach. You use it, there's no philosophy. You go there directly. I love the way in which it's written. It's literally having a mentor on your table side, on your side, that can teach you and pass you step by step through single procedure. I mean, other than the introduction, your chapter 3 is how to set up a minimal invasive cardiac surgery program in your own department. And you go straight ahead to the points that you have to do. What is your process? Understanding that you have financial limitation, because we all have. It's not that the administration is willing to pay millions of dollars for you to learn something new. So how to deal with that? Which cannula using? Which retractor? Chapter 4 is your instrumentation and operating theater in minimal invasive cardiac surgery. And you go through the details of each retractor, each technology, each tools, what are the essential one and what are not the essential one. And the second thing that I found very important is that it is true that we have Professor Google, and I'm an absolutely believer in it. I mean, I always go and review YouTube before big surgery that I have to do the next day. But on the other side, it's also true that it's so much information that you can get lost in you need a place that somehow has scrutinized the quality of the video that are available for a specific topic that can be minimal invasive aortic valve, and provides you with the best video, the best talk, and the best step, well processed, well digested, for you to being able to use it in your own activity. So this was absolutely excellent.
So I would say I would like to agree with you. Yes, the book unfolds in two dimensions. One dimension is what you read, what you have in front of you, which is this is the book, okay? So, and this is as in any other book, this is the dimension you would expect to enjoy. But then it's what is hidden behind the QR codes. That's a totally new dimension of content, which you can enjoy basically by scanning. And, you know, unfortunately, in the COVID pandemic situation we're living right now, one of the collateral benefits is that we all became QR code experts, you know, check in, check out. So yeah, I didn't know it's so easy. So in a way, the book is goes with the trajectories and the trends of the time. If you allow me to make one addition to what you mentioned, I was myself very privileged, and I guess I feel compelled to say that. The realizations I made and introduced in the book for the training of minimal invasive cardiac surgery arise from a lot of proctorship. I traveled in many countries around the world and tried my best to help local surgeons to start their minimal invasive programs. And you will be surprised. I'm sure you know, as a world-class robotic heart surgeon, that if you just see it in the conference, you can't really translate it one-to-one back home. It's not so easy. There are so many issues that play a role.
Yeah.
And in that sense, I was very, very privileged when I first learned and started back in 2008, because my institution, the National University Heart Center, embedded within NUHS and the National University of Singapore, is a very prolific, very supportive environment, which basically supplied me with all the premises, with the equipment, and with the money I needed to train myself, the team, and equip our program and grow it, after all, because it's not about just doing one operation in minimal invasive. It's a whole world, heart valves, bypass surgeries, arrhythmia surgeries, and so on and so forth. And so I'm very thankful for that. And so I was always exposed to that contrast of, you know, very wealthy country versus developing country. So I had to adapt my teaching to the real world.
Yeah.
So many times people tend to come to my operation theater from other countries, and they see, of course, a nice, fancy, high-tech operation with endoscopes and 3D cameras and core knots, and, you know, but we cannot take it for granted that they will go home and be able to remember everything. So it's very important, along with, let's say, an educational tool like a book like this, to have access to the visual content, because let's face it, we're visual animals. The most powerful way to impregnate information is visual. It was said that a picture speaks more than 1,000 words. So I thought that a video speaks 1 million words.
You're absolutely right. And it's incredible how you came out with this idea, and the process of writing and making it perfect really hit the time of a moment, of an historical moments where, as you were saying, QR code are becoming part of our life, part of our daily activity. And for sure, nowadays we need to create our own video library. You know, I record every single procedure that I perform, or Sam Balky, that I'm working with him here at University of Chicago, perform, because I review all of them. At night, I just put them and I watch a video randomly from the one that we have performed, and you can learn so much by reviewing yourself. It's one of the, you can understand the economy of motion. You can understand difficulties. How could you overcome? And you are in the comfort of your own living room. You are not in the stress of the OR performing within an entire team. And this is extremely important. It's a process that is extremely important to implement your outcomes and to improve your skills. So, absolutely kudos to you for this project. How long did it took from the time in which you had your idea to the time in which the book is now out last week? What was the entire process?
It was a lengthy and laborious process, I must say. It's not so easy to write a very subspecialized book. Most importantly, it's because we have a large number of amazing co-authors. So see, these are some of the authorities in the field around the world. And I would like to use this medium here to extend my regards to them and thanks people like Hugo van Herman, Jose Luis Pomar, who offered the introduction, Johannes Bonatti, Mark Rule, Michael Valelli, Vino Turani, and it goes, or the list goes on, about 35 people. We have the Texas team in aortic surgery. So, you know, it's very difficult to coordinate these people to deliver the chapters. I'm sure you know from your own experience. So keep the deadline. So I had to do, one of my jobs as the chief editor of the book is obviously to chase the co-authors to contribute their chapters and then do the proofreading and all that. To that extent, I had amazing help by the publisher, very diligent people, a big team which spans across continents. They have offices in London, in New York, and then secondary offices even here in Singapore. So they facilitated the process. Now, the whole process took 3 years.
Wow.
Until we can hold the book in our hands. So you would be thinking, wait a minute, would in those 3 years heart surgery knowledge and skill not double already? Don't you have to update it? Yes, we did. In fact, when we had the final draft, just before we gave it for print and processing, my editorial team, some amazing people I'm going to mention and thank at this stage, we went through one more time and updated the content, which is now basically a few months old. So very, very updated. So
and that's amazing. Amazing.
Yeah.
So and I found it. Yeah. No, please.
Yeah.
Go ahead.
And I cannot miss the opportunity to thank them, my editorial team here, some of whom are surgeons in our department, vascular surgeons, cardiac surgeons, people allied health, and I would like to single out Mrs. Peggy who helped us put it together. The one man that contributed chapters and did a lot of the last-minute editing work day and night, 24/7, is Dr. Fazi Sazat, a brilliant surgeon for Bangladesh who trained with me here in Singapore in minimal invasive heart surgery, is now doing his PhD. Doctors like Guo Hao Chang and Jai Sule and QQ and all these people are brilliant heroes basically who had to suffer my pressure so that we can deliver on time.
Yeah, the efforts, I'm sure that was an incredible efforts to do this two-dimension, as you said, is a two-dimension book. So I'm sure that reviewing the entire content and reviewing all of the videos that the QR code are associated with is an effort that must have taken really a long journey to all of your editorial team. I was extremely surprised to see such a complex and thorough book that include among the most innovative technologies, and most importantly also not only minimal invasive cardiac surgery in sense of mini mitral, mini AVR, or mini surgery for atrial fibrillation, but also TAVI, also percutaneous approach for mitral valve, also percutaneous approach for the aortic, so TEVAR.
Yes.
Tell us a little bit more. What do you think? You're a senior surgeon. What do you think about the importance for now is surgeons to adapt, not to be hostile against TAVI, but rather to embrace it, to embrace these new technologies. The next will be the mitral. How can we incorporate in our know-how of skills? And what has been your journey with these transcatheter technologies?
Okay, Gianluca, thanks for mentioning the hybrid component of the book, which is transcatheter techniques. Well, our profession is becoming hybrid. We work in heart teams, hopefully balanced heart teams, and looking at patients together, share knowledge and skill. And if I wouldn't believe that the future belongs to hybrid surgery, hybrid combinations of surgery between heart surgeon and cardiologist, I wouldn't even bother to write this book. So the future is the future is coming very fast, faster than we think. Hemingway used to say, we went bankrupt slowly, and then suddenly. So we heart surgeons, we must adapt to the pace of the time, and we need an educational tool to do that in the most efficient way. I was asked in an interview in Tokyo at a Medtronic event, and David Taggart was sitting on my side. So we both agreed that the future is hybrid. So we cannot single out one procedure being a solely cardiac procedure without the cardiologist, and vice versa. That's why the future also belongs in hybrid heart centers and not strictly surgical departments or cardiology departments per se, which we realize, which we materialize, and we employ here in our institution as well.
That's excellent. So when you wrote this book, who do you thought were potentially the readers? Who do you think is the ideal readers of this book?
Excellent question, if I may. The readers is, of course, the postgraduate surgeon. The surgeon who aspires to be a cardiothoracic surgeon or cardiovascular surgeon, who wants and needs to learn minimal invasive heart surgery. But not only the young and training surgeons, residents, fellows, and so on. The book is also addressed to any seniority of surgery. It can be an older surgeon who now decided to build up his minimal invasive program. So this is a very practical tool. That means that at the end of the book, for example, I even include the Cardex, the exact setup of equipment we're using in our operation theater, the needles, the instruments, everything. So that it's a one-stop target, basically, for all these surgeons to learn. But it's not only about the surgeons of all ages. It's about the nurses. So the nurses can understand, they can brief and debrief the surgery, and by a 1 fraction of a second scan can see how it's done before they go in the operation theater and do it. Also, perfusionists, of course. Also, anesthetists. We have 4 anesthetists from our institutions contributing the anesthesiology chapter. I would like to thank him here. Professor T. Lianka, Dr. Lalita, Sophia Ang, Dr. Sophia Ang, Associate Professor Sophia Ang. So anesthesiologists are equally so, because, as you know, anesthesiologists need to train themselves to be able to lead through the minimal invasive cardiac procedure. There are so many aspects that the anesthetist must know and do differently compared to basically what we used to do when we do median sternotomy.
That is excellent. And yesterday, while I was reading your introduction, that as I told you before we went live, I mean, that should be published, because it's just, you should buy, just that's worth the book. I'm saying, like, your introduction was just so straight to the point, honest, and very, very precise on what is the process of learning a minimal invasive surgery. And I was trying to get into, try to think a little bit about the difficulties that we have faced through the last 15 or 20 years to accept, as cardiothoracic surgeon, the minimal invasive approach. And as you said, citing Hemingway, now there is this huge interest in minimal invasive cardiac surgery, because suddenly we found ourselves in bankrupt with all of this new technology coming up that are not always in our hands, and with patients that are flowing away from us. So we are now trying to step up and rush through a process that we should have led 10 years ago. But I thought, and this goes really in connection with what you were saying, the importance in minimal invasive cardiac surgery to be leader inside the operating room, because more than in sternotomy, you need to work with a team, with your perfusionist, with your anesthesiologist in a way closer collaboration. What do you suggest when you proctor, like to how to create this culture of a team with your perfusionist, with your anesthesiologist, to partner with them and make them embrace your program? What is your suggestion?
Yeah. I couldn't agree more. I couldn't agree more, Gianluca. This is a very important point. You must become a team. It's all about teamwork and team spirit. So we have developed for our proctorships, usually these are 1-day events, 3-day events, whole week events, a 25-page syllabus where we go through every single operation step by step.
Wow. And
the syllabus is addressing anesthetists, perfusionists, nurses, and the surgeon.
Yeah.
So right from the beginning, we do it together. So when we proctor and here in Singapore or go around with our team, we make it clear that please make sure that your anesthetists are there. Or when you come to Singapore to learn from us, bring your anesthetists with you. I encourage all the teams that are aspired and plan to start their minimal invasive program to bring their anesthetists and their perfusionists with them. Of course, if they can bring a nurse as well, that is amazing. So communication is very, very key. I happen to be a hobby pilot, so they taught us in pilot school in Palo Alto, California, you must always divide attention. You must always divide attention, okay? So instruments, horizon, and communications, radio communications. So I think you will agree that it's the same in the operation theater. Totally. So anesthetists, perfusionists, and the horizon is the situs, what's happening inside the chest. Yeah. So what we're looking at, basically. And it cannot work without this cohesion, without this synergy.
I 100% agree. And I think that one of the risks or failure of minimal invasive program around the world in the past 20 years were led by the fact that too many heart surgeons has been with the wrong attitude. You use the words in your introduction, and you say there's no individualisms in the operating theater of a minimal invasive cardiac surgeon. And it is true, because if your perfusionist is not happy, if your back pressure on your arterial line is too high and it cannot flow, if the heart cannot stop, or if your anesthesiologist cannot do a single lung ventilation while you're doing an off-pump CABG on your left side, you are in trouble, and that's increased frustration. So you need to stop and make sure everybody is proceeding well.
Absolutely. And I think one of the great limitations, so when we proctor and teach, and that is reflected in the book as well, teamwork. Yeah, definitely. It is the interaction between all these components is very, very important, and there is no space for nepotism. Communication must be seamless in the operation theater. And one limiting aspect is the lack of communication. We are habitual animals, allow me to say. We like to sit in the comfort zone. This is one other problem, for example, that some surgeons still believe in the year 2021 that minimal invasive is bad. I understand surgeons who prefer to do the median sternotomy. We do it also, all right? Minimal invasive is not entirely adopted around the world, and it's perfect so, okay? So, but some people hesitate to move out of the comfort zone. Entropy, so to speak, is another force that forces us to be rather very conservative. And then all these barriers, in order to break and move the surgeon out of the comfort zone, the perfusionist out of the comfort zone, or the anesthetist to trouble himself to put in, you understand what I mean, a double lumen tube. And in some programs, cannulate the jugular and all this. You understand that it takes some conviction force, which can only come with sacrifice, Gianluca.
Absolutely agree. And I think the book really helped to bring down and dissect down all of this concept that has never really before verbalized. You think that minimal invasive is a smaller incision where you go in, you put a camera, and you're now operating. That's just the last aspect. But actually, minimal invasive is probably more, and you state very well in your book, it's more about the corollarium, what is around you, how you are perfusing the patients, how you are arresting your heart, how you are doing this type of procedure. So tell me a little bit more about your personal recipe for a mitral. You have, let's say that you have a P2 prolapse, a patient comes, is in his 50s or 60s, it's a young active man, what is your minimal invasive approach that you favor in your center right now for a minimal invasive mitral valve surgery?
Right. Very, very nice question. So we're at the endoscopic stage now. We're moving, and all those people who I have trained, they will start moving more and more in using the camera and not their eyes anymore. So we're using a small lateral incision, about 4 or 5 centimeters, which moves more and more to lateral as much as you gain experience. You may be thinking, as a genuine robotic surgeon, whether we're doing robotic. Not as of yet. In fact, back in 2009, I started the heart valve robotic program in our institution. But then over time, we became manually or endoscopically so good and develop our own technique of single incision minimal invasive cardiac surgery without groin cannulation, with percutaneous cannulation, with the Medea Glauber clamp, for example, and other tricks, and which of course allows you to do the entire operation through a single incision without too many ports. And as we speak, in our laboratory at NUS, a medical school, we're developing a new retractor camera, which basically does away with the camera and the camera holes and all this real estate that you lose. So these are what we're working on now moving forward.
Excellent. Really, really cool. And give us some of the tips. I loved the part that you spent in the book also, as I was saying before, about mitral percutaneous. And you really put all of the latest technology in your book, from a mitral clip to the Tiara valve, the AcuFet, the Tendine, Cardioband, Neocord. So there is literally step-by-step how to perform all of these innovative technologies and innovative techniques. Where is your what do you teach to the trainees and fellows that pass in your institution about this percutaneous solution of mitral valve? How should we learn them? And what is the role of the surgeon in the future of this percutaneous mitral valve treatment?
Yeah, you mentioned very many important issues, Gianluca. Thank you. So look, first of all, I would like to declare that, of course, our book doesn't claim full completeness, that it covers the entire field of hybrid transcatheter and heart surgery procedures. It's mainly a surgical book, but in the hybrid part of it, it touches upon all those matters because we need to start, working them up in our mind and get the training going for our residents. So the transcatheter mitral clip, for example, was written by an amazing cardiologist, Alotaibi, from Saudi Arabia, and trained in some of the world's best institutions. And it's a very, very nicely done chapter, very well structured. All the transcatheter mitral valve techniques were done by some of my residents, actually. And in collaboration with our amazing cardiologists, they contributed 2 chapters in transcatheter techniques, Edgar Tay and Ivandito Cugiono. So absolutely is a must. So we would like to start from the residency. So as a FRCS and a English weighted, a Royal College weighted system, we have a very, very nice structure of training, which just now in the last couple of years started accepting and absorbing more modern techniques. For example, transcatheter techniques. So we have a joint program in Singapore in which now we will dedicate time for our residents to spend learning catheter skills. I think this is important for every surgeon in the future. I think we have to move away, Gianluca, from the very, very rigid That's my personal view in the years to come. Very rigid 2+4 or whatever, 3+3. We need a very, very specialized training to produce basically the specialists of the future.
Totally agree, Theo. I can't agree with you more. I think we should embrace, first of all, percutaneous. It's an incredible opportunity for surgeons. I mean, you use percutaneous potentially for the peripheral cannulation, just per se. Cannulating properly a femoral artery, a femoral vein during a mitral, and you can do the mitral as you wish, endoscopic, transaxillary, robotic. I'm the most favorable surgeon for more technologies and more approach. I always love to hear what other people. I don't think robotic is better than anything else, but I'm here to say let's move in different this profession of minimal invasive cardiac surgery in different aspects through different technologies. But it's very important to be very safe while you are percutaneously or you are even surgically cannulate your femoral vessels. And these skills comes from a percutaneous, knowing how to use a wire, how to sit your wire in the superior vena cava, how to properly advance your femoral vein, and make sure that you do not encounter any type of complication.
Yeah, we did go to the very detail of practical tips, basically. Can I share one which may sound funny for you, very basic? When my resident is cannulating the groin and pushing the wire up the IVC, right atrium, SVC, he's concentrating on his part, and sometimes he misses to communicate with the anesthetist. The anesthetist is concentrating on his or her part, and the screen of the echo is turned to the face of the anesthetist and not to the surgeon. Yeah. This little thing of the resident, tell them, do you see where your wire is going? Did you ask the anesthetist to just tilt the screen so you can see as well where your wire is going? The moment you percutaneously cannulate, the moment you put the needle in, you will see bubble in the right atrium sometimes. So these simple tricks can, if you neglect them, they can cause disaster. So, and the devil is in the detail in minimal invasive cardiac surgery. So if, let's say, your approach is very well structured, commanded by a very clear syllabus, brief and debrief, then I think your residents, your trainees are in a safe place to learn it properly and avoid disasters. And I'm proud to say that we have very, very little complications in the learning curve. By the way, may I share with the audience, because you mentioned robotic, we are looking forward to the next generation of robot. And I would like to share with the audience that we have, as we discussed, we have declared you as part of our steering committee and advisory board of our Center of Excellence in Minimal Invasive Cardiothoracic Surgery. I thank you for making yourself available.
It's a pleasure.
So you can't, it's an important aspect which I write in the book. You can't build a program of global value, of global contribution, or a magnetizing minimal invasive program if you don't have friends and colleagues who are thinking similarly around the world.
Yes.
To exchange yourselves, to get corrected in your track, and so on and so forth. So network is very, very important.
It's huge. I absolutely agree, and I think I'm the representation of it. I keep in touch with everybody. I always share and I share even sometimes, my complication, or like recently I was cannulating a femoral vein, and it was I don't do percutaneous. I cannulate above the inguinal ligament. I learned this one from Sam Balky, and I had a complication with the cannulation of the vein. I was able because I bended the wire. And I think that the wire that I was using was not ideal. So you start to ask, what is your wire? What wire do you use? And you can hear so much and you can learn so much of a more heavy wire that can hold the cannula better in place and avoid to get bended. And when you have a bend in the wires, that's when complications start in the peripheral cannulation setting. So it's important to just review, having this open conversation with the friends and leaders around you. And as you said, to have a network that allows you at night to just text someone and say, hey, what I could have done differently, how do you overcome this problem? Otherwise, become too much and become you just quit. You say, this is not safe. I can't take it. It's too much to take on myself. Just forget about it. And that's what has happened, in my opinion, for the last 15 years to way many centers around the world.
Absolutely. And I think the wrong thing to do would be to think that you know better. You're not open for new information, for self-improvement, self-reflection. And you think that your technique is, let's say, the holy grail in this or that surgery. To this level of my experience and to this age, I travel every year. I go places to learn and adopt new techniques, as we did recently, a few years ago, with the del nido cardioplegia, for example. We were not using del nido cardioplegia. So we adopted it while I was proctoring in a developing country. So, and now we use it, and it works very, very well for us and make things easier for the training process as well.
That's excellent. And I love the way in which you said, because I'm sure that by proctoring and by looking the process of learning of someone else, that's an incredible tool for yourself. It's an incredible experience for yourself that then you translate it to your own patients. So I'm sure this book comes with a lot of tips, because you have seen the mistakes, or you have seen the process of numerous surgeons around you, around the world, that you help establish their minimal invasive cardiac surgery program. So, and that's why I think this book is incredible. And the title is extremely well chosen, A Practical Guide, because from the first chapter here, you go direct, it seems to have you in the room, like you are present there with the reader, and you're teaching him that specific step or that specific tool of the surgery itself.
Yeah. The book basically links you to all this content on the internet, CTS network, VuMedi, what you guys are doing in Chicago, some amazing things. It's all hidden behind the QR codes, basically. So it comes alive, and you have the opportunity to see. Ultimately, I'm not going to force anybody to do it this or that way. That's why the book also has sub-chapters, alternative techniques, how others do it.
Yeah.
Okay. But I think it comes down to following. It comes down to the connection between the brain, manual, and solar plexus axis for any surgeon to be successful. Okay. So these three modalities basically, which have to harmonize when you start something new. So you measure yourself, but then you have to be appropriately aggressive. Don't be deterred. I'm addressing the audience now, the young surgeons out there. Don't be deterred by economical issues, by pandemics, by how your colleagues are treating you. You know, somebody waiting around the corner for your complication to happen. We have these issues in many developing countries, you see. So
not only in developing countries. So we have these issues everywhere around the world. So
yeah. So in one way or the other, the book is addressing all this and gives basically practical tips how to make the minimal invasive program, how to incentivize your leadership, the other team members, and to achieve what we call incentive alignment, so that everybody co-owns the program and together you move on forward.
This is incredible. Among the chapter on how to do it step by step, there is a very, you write like 6 bullet points. You write, don't hesitate, don't procrastinate, don't listen to naysayers, those that tell you, no, it's not possible to do it.
It's not possible. The mitral valve, you can't see the mitral valve properly in minimal invasive fashion.
You don't say it. Then you say, don't fear competition. And that's don't isolate. And we were saying, because like it's important to maintain a networking, and don't keep it for yourself. And I think like these 6 points, last night I was just mesmerized by it. But this is a very brief sum up of exactly what is the journey of a minimal invasive cardiac surgeon and what it should be. So I found it extremely valuable, extremely successful. We are opening to any question that comes from the audience who are following us through our social media. You guys can write any question on YouTube or on Twitter or on LinkedIn, and we will see them publish here directly, and we can have them for the author. And I want to, in the meantime, while the questions are coming, I want to ask you a little bit more about the overall aspects of this book, meaning where do you see, like, do you generally prepare before your surgery, before a mini mitral nowadays? Do you prepare yourself? How do you prepare yourself? Do you go on YouTube still, or do you review your own video, or you just check the echo and nowadays you feel very comfortable with your technique? What is the night before Theo Kofidis, before a mini mitral? How does it look like?
Okay. All right. As in your case, I think a minimal invasive procedure now is an extension of our own selves. I don't think it's so exciting, so dramatic, but you're right. Where I go to, if, for example, I would like to diversify my technique a bit, is YouTube. That's number one. Is the platform we're using today. Yeah. Or I know, for example, that you presented something in some conference or some bulky or any other top minimal invasive surgeon around the world, and I want to diversify and enrich myself, and I can watch it. I watch CTS network videos, I watch VU-Medis, and so on and so forth. But that brings me back to my amazing team of surgeons who I taught and I'm teaching how to do minimal invasive heart surgery. They're so amazing. And if you're embedded in the team, Gianluca, we have an amazing team at the Department of CTVS at the National University Heart Center. You can rest assured. You can go to sleep much, much easier.
Yeah.
So, because if there is something missing, one of you guys will pick it up. So it's an interaction before and during the surgery. How many times I buffered my own self with an amazing team around me, and vice versa.
That's absolutely important. I think, again, this is leadership, and is leadership inside the operating room, and it is absolutely a must to have or to develop to be successful in the business of minimal invasive cardiac surgery. Otherwise, you're going to set yourself up for any success. When you think that it's only about you and what you are doing, it's necessary to communicate and to have a nice, soft-spoken communication among all of the other members. When you're doing a mitral, how do you arrest your heart? You mentioned the needle. Do you give antegrade only? Do you use your percutaneous? Do you place your percutaneous retrograde catheter from the anesthesia? I heard that probably the company is going to withdraw it. What is your point on it?
I'll start with the last in a reverse way. You're right. We always wanted to use the coronary sinus catheter transjugularly, but it was never available. So probably there are some market penetration issues here. So as much as it sounds paradox, within our progressive minimal invasive program, I am a bit conservative here. So I use the Chitwood clamp and antegrade cardioplegia, the usual Medtronic extended cannula, which is valved at the tip, so and that takes care of it.
Sure, and you put your cardioplegia through your thoracotomy, correct?
Yes, through the thoracotomy. Most of the times, I've done endoscopic transareolar through the nipple cases where you can be creative. Of course, you can put an extra hole somewhere, and I don't want to overcomplicate things because we are teaching a lot. So we really like the people who come visit us to go back home and have a low threshold to start the program and adapt the technique.
Absolutely. And how do you de-air a mitral in a mini mitral thoracotomy? Do you leave your antegrade cardioplegia needle there and then you remove when you are already off pump? That is kind of scary. Do you keep your vent through your valve and then you de-air from there? Yeah. How do you de-air?
Very important question, which everybody asks. Thank you for initiating this discussion. Okay, there are a lot of tricks and tips here which are in the book, basically. So you heard about the Coca-Cola effect. Most of these surgeries are done with CO or champagne. Sorry. Okay, so
I take the champagne one.
You take the champagne one. All right. So most of the surgeons are doing minimal invasive surgery with a CO2 insufflation. That means we flood the field with CO2. And so what happens is during the time of the operation, the heart is open, it absorbs CO2 and so on and so forth. So in the end, we think it's open heart surgery, like median stenotomy. And I would correct myself. We think it's median stenotomy. And so we start shaking the heart and shaking the table in the end. But what this does is produces more bubbles. Okay, so CO2 goes out of solution, produces bubbles, and that's the Coca-Cola effect. Take a bottle of Coca-Cola or champagne and shake it. You know what will happen. So fill up the heart, blow the lungs, head down, Chitwood clamp is still on, and evacuate as much as you can from the antegrade retrogradely through the cardioplegia side. That most of the time does it. Now, when you remove the Chitwood clamp, leave the head down, continue filling up, leave it a few seconds until the first couple of contractions, and I only raise the head when I have some contractions and potentially some very, very slight ejections. So everybody has his own technique, I guess. Now, you mentioned the vent in the left atrium or in the left ventricle. I only propagate it into the left ventricle only if I have trouble with my cardioplegia, very, very long operation time, when I have suspicion from some anatomical complications, or the heart was not properly cardiopleged and I had, let's say, some phases of VT during the procedure. So in those cases, or let's say you do a redo and you do it on the fibrillating heart. Right. So then the left ventricle, of course, doesn't recover so easily. So before you close the atrium, I push the vent into the left ventricle to have some sort of relief and evacuation of the left ventricle until you have strong contractions. This is what we do.
Excellent. And I think, again, you know, the devil is in the details. These are exactly those details that you speak in the books and you dissect and analyze in the books, and are essential, because at the end, the hearing, that it's something we don't even think about when you are through a sternotomy, becomes an important and very crucial step in your minimal invasive approach for a mitral valve. In any way you want to do it, transaxillary, minimally transareally, endoscopically, robotically, it doesn't matter. But the reality is that the step of de-airing a heart after a mini mitral is a very crucial point, and you have to have a strategy for yourself. You have to have developed a team strategy for it.
Yeah, you can be very resourceful and creative. Even some cases where there is a bubble, the darn bubble that doesn't want to go away, you can always turn the table to the assistant or to the other side, so that your cardioplegia cannula, which hits the aorta anterolaterally, now becomes on top. So you give the bubble more chance to leave the body, basically. So like simple tricks like that, but they're important. Otherwise, you sit there, the heart fibrillating, VT, whatever, and the air is not coming out.
And then you remove your cardioplegia needle from the aorta at the end when your Chitwood is out. So your cardioplegia stays in for a little bit. You complete your de-airing. At that point, when you're satisfied, you go up with your head. And at that point, you remove it with you fix it with a core knot, or no?
Not yet. I never remove my cardioplegia cannula until I see that my mitral valve result or aortic valve or whatever it is excellent.
Very good point.
So I let the heart, usually I operate at relatively moderate temperatures, 33 degrees, 34 degrees. I follow the Lamella school in that. So I don't go down below 30 unless it's a very, very long procedure. So that means that the heart usually recovers within seconds when you have used del nido cardioplegia. The ventricle is in good shape. Wait for 2-3 minutes for the ECG to fully normalize, and then tell the perfusionist, fill up the heart, let it eject. The anesthetist can see within 5 seconds whether your valve repair has worked or not. So once I know that it's good, then I start removing things and start the landing process of the aircraft.
Absolutely. I love this connection that you made with piloting, and I think that is extremely valid, because if you think like piloting and flying, it's an extremely safe procedure, very complicated, and people train themselves highly, and there's a very stepwise approach. You don't are going to sit on your 737 Boeing full of people, full of passengers, if you have not performed all of the steps, all of the certification, all of the potential complication in a simulator lab. And this is something that we need to do more as cardiothoracic surgeon. We have to shift away from patient-side teaching to simulation lab teaching.
Simulation is very important. In fact, we were very fortunate because a very wealthy patient who I operated, I gave him a rat, right anterior mini thoracotomy for aortic valve replacement. He did very well, and so he donated a large amount of money so that we set up a unique simulation center at the NUS, National University of Singapore. They gave us an amazing space. It's not that we have basically, what is the uniqueness? We have all advanced equipment in the world, all in one room, basically, where we can take rotations and can train up to 48 people. That means we have 2 Maastricht mitral valve simulators for robotic and manual training, endoscopic training. We have a lot of Japanese beat simulators for beating heart, off-pump beating heart, revascularization, and so forth. We have the Mentis simulators for TIVAR, TAVI, which simulate catastrophes. You have to find out what's happening, like a flight simulator. So it's all in one. And of course, we have the Chamberlain torsos, where you can do minimal invasive mitral valve, aortic valve, bypass surgery, everything. So we're just waiting for the COVID pandemic to ease out on us, to leave us alone, so that we can welcome bigger teams and train them.
This is an incredible opportunity, and I will say that everyone who is online now should think seriously. I'm thinking by myself, I will come for sure and visit you. I want to bring some of my teammates and together spend some time, because there's nothing more important than go see, understand, vision it with the rest of your team and spend some time in a lab. This is something we need to do more. And every young cardiothoracic surgeon should imagine to spend time if they have not had the opportunity. And you say that in your book, if you don't have the opportunity to see it inside your own institution, don't be discouraged. Find an opportunity, find a fellowship, and you suggest some of the places where you can learn, where you can train yourself. Find yourself the time. And there's never an age in which you shouldn't imagine yourself to learn. That's why you should still buy a book, read it, and spend time on it, because it's never too late to learn something new, to refine your technique, to adapt, to change. And we need to change because these specialities is changing way faster than our mind is capable to imagine. So we need to stay ahead of the curve and not behind it.
Absolutely. And I must confess that I had my opportunity also, and it will be wrong not to basically give it back to younger people. So it would be inappropriate if I don't mention who gave me the opportunity and who fired those pistons in me, basically, which generated the minimal invasive program, which is now a very, very strong international platform. So this is the person I dedicated the book to. Offline, you asked me very sensible questions. You told me, Theo, how did you find yourself in Singapore?
Yeah.
So I was very fortunate to meet, totally coincidentally, at that time, chair of the department and chair of the university surgical cluster, Professor CND. This man, who is now not an active cardiac surgeon anymore, but still around and very active, he's the one who brought me to Singapore and gave me this amazing opportunity. And when I felt that it's time for me to progress to the next level, we didn't have minimal invasive heart surgery as a platform in Singapore. So I went to him and I said, Cien, can I please go to Randy Chitwood? Can I go to Hugo Van Herman? Can I go to here and there to learn, to Joe McGinn in New York? Yeah. And he was so open-minded and supportive. He told me, Theo, tell me what you need. He gave me all the money to move my team multiple times around the world and to set up the program, to buy the equipment. So the book is dedicated to him, to Professor Cien Lee, with endless gratitude for this support over the years.
This is fantastic. The journey of your life and this dedication is excellent. And I think it's the best way in which we should conclude this life we are hitting now, 1 hour. And I think, Theo, I want to thank you so much for this incredible book that you just, together with all of the team and the help of the other authors, have created. I will extremely encourage everyone to have it, to leave it on your desk, in your office, at home, to review it before your case, and to just read it very carefully, because it's full of tricks and tips, very, very oriented, a surgeon to surgeon, and that's the uniqueness of it.
Well, I would like to, first of all, thank you for allowing me this opportunity to share the news of the book. Gianluca, congratulations for your channel and this very, very important and inclusive activity. And I will also like to thank my institutional leaders for providing me and embracing our progressive spirit with their own progressive spirit and giving us all we need to teach and to develop such program. Not excluding the very, very active director of the National University Heart Center. So thank you for the opportunity, Gianluca, to address our younger generation out there.
No, thank you, Theo. Thank you for this fantastic new tool that you are providing to the entire community. Thank you for all of your efforts and your contribution in this community in minimal invasive cardiac surgery. Looking forward to meet you in your lab. I want to come visit, learn. I need to learn more, and definitely one of the stop will be your center and will be your amazing team. So thank you everyone who participated today through all of our social media platform. Looking one more elements actually. Where I want to buy the book. Where should I go right now?
Oh,
tell me where I should go.
Yeah. Professor Google. You hit in Google the name of the editor, which is myself in that case, and a practical guide or minimal invasive cardiac surgery practical guide. By the title alone, it will pop up the major 3-4 online vendors. For example, Amazon, Rootlege, ROUTLEGE.com.
Yes.
Barnes and Nobles, Booktopia. All the major vendors around the world are offering the book. It's not very difficult to any platform online. You will find it.
Is it? Do you buy there is of course the hard copy? Do you have also any Kindle or online version that you can download?
There is an electronic copy. All opportunities are available, but mostly basically is the hard copy. Of 425 pages that is available on order.
Fantastic. Perfect. Theo, thank you so much. It was fantastic having you here. Looking forward to meet you. Looking forward to this pandemic to be over. And finally, we never thought we miss so much going to a medical meeting. But I think we are all missing a human and social connection with friends, where we can talk, we can learn, we can exchange. In the meantime, this Saturday morning or Saturday evening appointments are here to try to bring a community together and talk about topics that we love. Thank you again. Thank you for this contribution, and looking forward to an extremely success of this book because it's extremely well written. Thank you again.
It's reciprocal. Thank you very much. Thank you. Bye, everybody.